Good afternoon. This is Genevieve Kenny. I'm one of the co-directors of the Urban Institute's Health Policy Center. I want to welcome you to today's convening on maternal health inequities during the COVID-19 pandemic and say how grateful we are to our panelists for sharing their time and their expertise with us. Some quick housekeeping items before we get started. First, the event is being recorded, and the recording will be posted online after. All of the slides and speaker bios are available online at urban.org/events. And I know Haley's going to be putting links to those in the chat. Third, all participants are muted, but you can send questions or comments in the Q&A box at any time, and we really encourage you to do that. And we encourage you to upvote and comment on the questions and comments that others share. And finally, if you are live tweeting or tweeting at all about this, please use the hashtag #LiveAtUrban. Well, now to the main event. We are very fortunate today to be joined by Mona Shaw, our project officer at the Robert Wood Johnson Foundation, who's provided invaluable guidance and support to our work. Mona is a PhD epidemiologist and senior program officer at the foundation. And I'll turn to her now to share some opening stage setting remarks for the panel. Thank you.
Thank you, Jenny. Good afternoon, everyone. On behalf of the Robert Wood Johnson Foundation, thank you for joining this important conversation about birth equity and maternal health. So we at the Foundation are committed to building a culture of health, which means every person has an equal opportunity to live the healthiest life possible. But unfortunately, the prospects for good health are sometimes limited by where we live, how much money we have, and the discrimination that we face, as evidenced by the staggering maternal mortality statistics, especially in Black and Indigenous birthing people. We know the persistence of vast inequities in maternal outcomes reflects an ongoing failure to confront the reality of structural racism, class, and gender oppression. For us at RWJF, we know that to achieve a culture of health, that requires us to address racial equity, and we're committed to doing so. So there's many tools RWJF are supporting to help achieve racial equity, especially in maternal health, including supporting community organizers and racial justice groups who are changing narratives, developing new leaders, and at the ground making the much needed policy and systems changes. We're also supporting research that can help elevate promising solutions to maternal and child health inequities. And when we fund research, we're committed to equitable evaluation principles and ensuring that communities and people that are most impacted by oppressive systems are true partners in the process. So we're so excited about the new work that Urban Institute released today, done in partnership with community members, organizers, policymakers, and community-based providers. So thank you again to the Urban Institute team for organizing this important convening, and thank you to the panelists who are sharing their time and wisdom with us. I want to now hand it to one of the leaders of the project, Dr. Kima Taylor, a pediatrician and non-resident fellow at the Urban Institute. Thank you.
Thank you so much, Mona. And I would like to thank all of you for joining this conversation. Times are rough and a bit exhausting, and so really recognizing that watching another webinar is a commitment that you've made, so thank you. I want to give a bit of an overview. I'm going to give a bit of an overview of Urban Team's findings, and then I'm going to leave time for the panelists to do the question and have a question and answer. We don't come bearing complete solutions. I want to be frank with that. We leave you with ideas and important questions, and we hope such questioning can help identify and create solutions in community post-COVID so we might achieve equitable maternal child health and health outcomes overall. In the interest of time, I'm going to go quickly through and not adhere to the slides, but give you a sense of who the team is, what the methods were, and a brief summary of the findings, mostly in kind of a story type setting. I think to get to the punchline, in case I can't talk fast enough within my time period, the idea is these are ever-changing times. Really, to have impact, we need to listen to the people on the ground who are most affected and use that to guide our policies and our systems, because often this is the way to make sure people have the best outcomes possible. So just to give you an idea, this is the Urban Institute team that worked together. I think, hey, it's working. And give you a sense of the methods. In spring and summer 2020, we conducted individual and small group interviews with about 40 maternal health experts, perinatal care providers, consumer advocates, philanthropic funders, and frontline health workers that serve women who are pregnant and people who are pregnant to identify and examine key concerns about maternal health equity and challenges raised by the pandemic. We also conducted and periodically updated a comprehensive scan of publicly available information on maternal health equity during the pandemic from national policy and research organizations, professional provider trade organizations, and leading maternal and infant health advocacy groups. Sorry, I'm tech challenged. Okay. Our findings primarily reflect insights into and responses to the pandemic that emerged between March and September 2020. Because of social distancing requirements and the urgency of this topic during the pandemic, this analysis does have limitations. We couldn't interview mothers directly, and though we interviewed provider and advocate stakeholders, we recognize this does not adequately represent mothers' point of views. In addition, our interviewees were predominantly on the East Coast, but we acknowledge community needs and realities differ by location and understand the importance of authentic community voice, partnership, and engagement as solutions are developed, implemented, and evaluated. We center this work, part of Urban Institute's larger Transforming Health and Healthcare Systems project, around the Center for Social Inclusion's definition of racial equity. When people, including people of color, are owners, planners, and decision makers in the systems that govern their lives, and society acknowledges and accounts for past and current inequities and provides all people, particularly those most impacted by racial inequities, the infrastructure needed to thrive. These are the 4 briefs that we developed, and I really hope that you go and find them and read them in depth. And the slides and bios and other information are on the right-hand piece. But I am not going to do these 4 briefs justice. I want to be upfront, and that's because I really want you to have time to be able to listen to the panelists and really hear frontline conversation about how they've pivoted and how they've really fought to achieve and provide patient-centered, culturally and linguistically effective services. So as Mona stated, the United States has been experiencing and at times battling racial and ethnic maternal child health inequities for years. Pre-COVID, states started to recognize and think about reckoning with such inequities. These efforts were at best incomplete. However, thanks to advocates' pressure and negative press, change was afoot. Policy responses were floated and in some cases implemented, such as extending Medicaid coverage for a year postpartum, requiring implicit bias training for perinatal providers, establishing quality review committees, all had a role. Healthcare systems changed as well for financial and more altruistic reasons. They started thinking differently, adopting pregnancy care bundles, engagement specialists, and quality initiatives. And while oft thought of last, but slowly gaining ground, and equally and sometimes more important, work was being influenced by the voices and desires of impacted people who were pregnant and those providers of any type, doula, midwife, case manager, OB, and others, who sought to provide patient-centered, culturally and linguistically effective services, who listened to and worked in partnership to create improved individual outcomes. Despite the burgeoning efforts, federal and state funding for culturally and linguistically effective maternity care, wraparound services, and community services had been inadequate and fragmented for years, posing significant challenges in the delivery of whole person and equitable perinatal care. In addition, consumers, system, and policymaker partnerships were challenged by the reality that to eliminate inequities, improve health overall, would require provider and payer investments in the collection of high quality, reliable, disaggregated data on maternal health care, health outcomes, race, ethnicity, and other key patient characteristics, as well as funding to support needed practice changes and trainings that reduce bias and disparities, and community-driven testing and evaluation changes in service delivery models. Then comes COVID-19, a new deadly virus with little precedent, maybe a little from the 1918 flu, but lots of fear and little leadership on how to safely move forward. Some policymakers focused on keeping consumers who are pregnant, their families, essential workers, healthcare staff, and all of us safe. Yet, there is little national consensus or national leadership on how best to do this, as information and evidence change daily. This shifting knowledge base had a profound impact on the healthcare system, parents, and their loved ones. To add to the scariness, we were asking systems and policies that had created and or sustained maternal child health inequities pre-COVID to become the foundation on which a new COVID response was built. Most of us realized that this was not an equation likely to lead to decreased disparities. And in addition, COVID strained supportive funding by redirecting money to emergency responses, placing financial pressures on culturally and linguistically effective safety net providers, and putting Medicaid programs at risk of budget cuts. Policymakers, for reasons that are always occur, the policies that policymakers put in place often lag behind the reality on the ground. And even the most effective seeming policies, like being required to provide COVID testing, often met externalities like not having enough COVID tests available. Hospitals and healthcare systems stepped in to rapidly adapt rules of their own to fill some of the larger voids. Systems showed they could rapidly change the way they practice, who practices, and the scope of these practices, including how people are reimbursed, privacy rules, and more. And at times when previously they'd been much slower to change. But we have to admit that the lack of consistent, reliable collection and analysis of disaggregated maternal child health outcome and engagement data does leave us uncertain as to whether these changes improved or worsened outcomes and or inequities, though the people we spoke to believe they were worsening the inequities. Telehealth, a practice slowly coming to the fore pre-COVID, became the star of the show. Many more people than imagined had access to personal phones, and when they did not, often foundations or state governments would step in to fill the void. Internet deserts became noted, and some governments invested in solutions, while in other areas, the digital divide remains, affecting access to care. In addition, there was little money to help providers build a capacity or infrastructure, much less to train them on best practices for providing culturally and linguistically effective telehealth services. The massive consumer desire for birth center births and doulas outstripped capacity because these services had been reduced previously, despite consumer desire pre-COVID. Healthcare providers and systems were desperate for safety equipment whose supply chains were expensive and erratic. In many instances, each individual provider or hospital was on their own. So even as hospitals and systems were trying to create rules that would both keep people safe and improve healthcare outcomes, they were working at a deficit. Policy and healthcare systems were in disarray, and this affects consumers' outcomes. But in a positive way, it could be an opening for the aforementioned partners to more directly engage with and listen to their diverse community consumers, as well as community providers who pre-COVID had sought to provide this culturally and linguistically effective patient-centered care, some of whom you will hear from in a little bit. These providers quickly adapted within changing rules to offer as best they could what their clients needed. Recognizing telehealth could offer some light, postpartum and behavioral health visits attendance increased, and these providers utilized those services. As parents no longer needed to leave the house, jobs, kids alone to go in for a brief appointment, often this was found comforting. Case managers at this time became telecase managers, creatively working to find virtual resources their clients need. Doulas adapted as well and trained others to become teledoulas. These community pivots were sometimes recognized, leading in some places to reimbursement for teledoula services, for instance, if the doulas were available. Working while providers and consumers alike faced childcare, homeschooling, isolation, employment, and disproportionate impact to the COVID virus and other social challenges. The culturally effective provider and pregnant consumer relationships were even more important as COVID's quarantine and economic effects were having profound impacts and increased stress on the people who were pregnant or birthing. Access to basic needs were difficult for myriad reasons. I just realized I'm not pushing the slides, but that's okay. Were needed for myriad reasons. Fear of leaving the house and risking infection, especially having a newborn at home. Uncertainty about which social services were available. Inability to, even if they left the house to say, go get formula, arriving at stores that only allowed you to have one formula at a time because of COVID-related shortages. But most profound of all the changes for many of the people who were pregnant was the separation. Birthing alone without an advocate, because safety rules meant no one in the birthing room, though these are changing. And even as advocates have been shown to improve inequities, they weren't allowed to be present in the room. Plus, isolation post-birth, when parents are unable to use in-person supports that so many of us needed and used when we had our children, not just for healthcare services or social services, but in fact, to help us make sure that we were becoming the best parents we could and help us retain our sanity. Finally, the separation of infants from their mothers for COVID or suspected COVID. Again, the US has a long history of inequities with regard to infant separation, and the lack of data should give us pause on how and whether COVID separations followed some of this implicit bias, though unfortunately there've been articles to demonstrate that it probably is. Now, during this next wave, with a bit of knowledge under our belts, may be the best time for policymakers, systems, foundations, culturally and linguistically effective providers, and most importantly, consumers to start collecting disaggregated data, discuss policy systems change and engagement practices to equitably improve outcomes while mitigating infection risk, each discussing from their own vantage point and reaching an informed compromise. This requires working in partnership to take some key steps that will lay the groundwork for decreasing inequities now and be a part of the conversation for post-COVID inequity eradication. So first, are localities collecting disaggregated maternal child health outcomes during COVID? And if so, are there inequities and poor outcomes? Where do these lie and how can they be remedied? And if not, how soon and what do localities need in order to start collecting this data? And this is not just health outcome data. We have to look at separation data, social determinant data, breastfeeding initiation data, and more. Are consumers able to access culturally and linguistically effective virtual or in-person services, even with insurance? It's one thing to expand Medicaid coverage or expand private insurance coverage, but if people can't actually access services, we have to think more deeply about how to make those linkages. And if they can't access those services, how can localities think about creatively increasing access to these services? Is it increasing practice scopes, decreasing state barriers to providers working across lines, increasing and diversifying the overall workforce, leaving a foundation for future work in this area? 3, are consumers able to safely address their basic human needs like food, diapers, breastfeeding equipment, rent, employment? And if not, can localities work in partnership, listen to the needs of their consumers, and invest in improving access and linkages to culturally and linguistically effective community-based social services? For like one example, where localities are offering SNAP customers to buy their groceries online so they don't have to go out. Could federal and state governments consider making permanent many of the telehealth and telephone policies, including those related to behavioral health services, while ensuring payment parity and collecting and analyzing disaggregated data to see if telehealth is exacerbating disparate outcomes for especially Black and Indigenous populations, and asking if relaxed HIPAA rules create privacy risk, particularly for people with substance use disorders, individuals with mental health concerns, and other stigmatized groups? Looking at this additional data and being able to think through ways to rectify and make sure those inequities don't continue. Localities could expand community internet access and connectivity and reduce the digital divide so all populations can equally benefit from advances made in telehealth. Medicaid and all payers could broaden and appropriately reimburse for the range of culturally linguistically effective services permissible via telehealth, including doula support, prenatal risk assessments, postpartum depression, social determinant screening, home visiting, mental health, and substance use disorder services, along with maternal support services. States with federal support that have not done so could look to permanently expanding access via extended postpartum coverage and/or adopt Medicaid expansion, and increase funding for culturally and linguistically effective home visiting and other proven programs so they may continue to provide vital services to families in need. But through all of these changes, systems simply must have the ability to assess if they are effectively and creating equitable outcomes. If not, they have to work differently and harder. Just because we're doing these efforts does not mean that they're actually guaranteeing safety, nor that they're improving outcomes. So we have to be diligent about collecting and analyzing disaggregated, de-identified data. Data collection efforts that support maternal health and equity improvements will require that providers and payers track multiple dimensions of healthcare practice policy, including staffing and reimbursement policies, and access to high quality, culturally and linguistically effective, respectful, and affordable prenatal and birthing care, and to offer supports and services to people who are pregnant and people who are new mothers need to thrive. I want to pass it over to the panel, but I did want to address two things. One, to provide a definition in terms of when I use culturally and linguistically effective services, what I mean is offering culturally and linguistically relevant services, but in ways that are going to improve health outcomes. It's not enough just to say we're going to offer the relevant services and people still die at disproportionate rates. It's how to work in partnership with people who are pregnant and make sure that their outcomes are shared outcomes, that you've come together to work towards health improvement. The other thing I want to say before the panelists is that we're really honored, and a lot of the information that we received was from them. And there's this great James Baldwin quote that says, "Those who say it can't be done are usually interrupted by those who are doing it." And these people are the ones who are doing it. And so I would like to introduce Ian Hill, who's a senior fellow at Urban Institute, who's going to run the provider panel part of the conversation.
Great. Thank you so much, Kima. And thank you to everyone out there who has taken time out of their day to join us for this event. It is really a distinct pleasure for me to introduce our panelists for the next portion of the program. Just as a little backdrop, when we were deciding who to invite to attend the meeting, we cast a really broad net, including maternal health care providers, federal, state, and local policymakers in Medicaid, Title V, and public health. We invited consumer advocacy groups, philanthropic funders, and health policy researchers, because we knew that each of you could get something out of the information that we'd be sharing today and be able to translate it to your area of expertise. As I reviewed the registrants yesterday, I saw that we had representatives of not all states, but 33 states, the District of Columbia, and even Great Britain. So that is pretty exciting. And in fact, all of these domains and roles that I just mentioned are really well represented. But when it came time to think about the speakers that we wanted to have with you today, we focused more narrowly on direct care providers. We invited 3 individuals who have been on the front lines of caring for pregnant and parenting people, their families, and their communities, who have been coping and wrestling with the challenges of COVID-19, and who've been working to address maternal health inequity and racial injustice in these challenging times. These, we believed, would be the most important and credible voices for all of you to hear at this time. So once again, it's a pleasure to introduce our 3 panelists. Their bios are available on the events page for this meeting. But first, Kimberly Lyles is the Senior Director of Population Health at Healthcare Access Maryland in Baltimore. Kim is a registered nurse and directs the Coordinated Care Program at HCAM, overseeing both community outreach as well as a team of care coordinators who work with maternal and child populations in Medicaid. Kim also represents HCAM as a core implementing partner for the Be More for Healthy Babies initiative, which is a collaboration of the Baltimore City Health Department and the Family League of Baltimore. Our second panelist is Aza Nethari, who is the co-founding executive director of Mama Toto Village, a not-for-profit community-based agency in Washington, D.C. Mama Toto Village is an organization devoted to creating career pathways for women of color in the fields of public health and human services, and also providing accessible perinatal support services that are really designed to empower women with the tools to make informed decisions in their maternity care, as well as their parenting and their lives. Aza is a licensed certified professional midwife and a family counselor. And our third panelist is Diana Jolles, who is a public health nurse midwife. She is finishing her 20th year of practice at this point and has practiced in Colorado, Texas, Washington, D.C., and Arizona. Throughout the past 2 decades, she's also been very active with the Birth Center model of care and serves as the research chair for the American Association of Birth Centers. Diana is one of 21 nurse midwives currently serving in Tucson, Arizona with the El Rio Community Health Center. So welcome to you all. It's a pleasure to have you here. I've got a series of questions that I'll pose to you over the next 40 minutes. I'll turn to each of you in turn to take 2 or 3 minutes to answer them. So let's get started. So my first question for the panel is, how has COVID-19 changed the way you work? And as you answer this, consider both how you reacted early on in the pandemic, as well as how your practice is operating now that you've had 8 months to adjust. Why don't we start off with Kim? Can you take that one?
Sure thing. And good afternoon again. And thank you, Ian, for inviting me to share my experiences, as well as what my team has experienced during this COVID-19. And let me tell you, we are a community outreach team. What we are most proud of is being boots on the ground and being in the communities in Baltimore City. And so as we had to make the difficult decision to close our doors and to really set up virtual offices in our homes, it was something that we were not prepared for. Let's be honest. We were embedded in clinical delivery sites. We were performing home visits, and that was our niche for being successful. And so when I had to make that decision and make that announcement to my staff to say, no community visits, we're closing the doors and we're going home to outreach our clients exclusively telephonically, it revealed a lot of vulnerable spaces for us as a nonprofit agency. We had to really look at our technology and our IT posture. You know, are we a part of the digital divide if we don't have the most up-to-date laptops and Wi-Fi and even telephones that allow you for those FaceTime and telehealth engagement? We had to take a moment to really retrain our staff to make sure that we were engaging our clients in the most appropriate way that also provided HIPAA protection. And we just had to take a deep breath. And when we did that, we started to really say, we can do this. At first we were like, how are we going to do this? But then we took a moment, and what we realized is that this was an opportunity to really reinvest in our workforce, to develop a new skill that they were only used to providing services face-to-face, but what would this look like in this virtual space? And then give them the training necessary to be successful there. And through this experience, we've done exactly that. I am incredibly proud of how we have taken a moment, looked at our barriers, and then made the pivot. Whether it was technology upgrades, training, even reaching out to our partners to say, I know we're known as an outreach program, but we're doing that outreach here from our desktops, and you can still depend on us for high service and quality care for our clients. And so we have really made that change.
Very good, very good. Thank you. Asa, why don't you take this next and tell us a little bit about how COVID has changed the way you guys work at Mama Toto Village?
Sure, thank you for that question. Similar to what Kimberly just shared, we also are completely, mostly in the community. The majority of our care happens in clients' homes. And it was difficult to make that transition to 100% telehealth when our clients so heavily rely on the services that we offer. And also so heavily rely on our organizations to also meet those social support needs that is very difficult to navigate in a telehealth space. We actually had different challenges with, well, not really challenges, we had a different experience with the technology because our staff were already equipped with iPads and hotspots. We were already prepared in that way. It actually made the transition and that pivot to online care pretty easy when we had to completely shut the office down abruptly and then have to communicate with clients, you know, the care is going to be moving completely online. So that communication that we needed to do for that first couple of weeks to clients, I think was more challenging than it was for our staff to have to pivot. One of the other areas that I think is often overlooked in this experience, because I think we heavily focus on what is happening on the client side. was what was actually happening with our staff. And Kimberly mentioned some of those staff vulnerabilities, but we think about that because often within our organization, we hire members from the community. We have to think about their mental health and their transitions that were happening at home with children not being in school and how that impacted their ability to work when people actually don't have childcare. And have to think about how am I going to school my child, meet the demands of my job while also attend to the needs of my family and my own self-care at the same time. So we had to think a lot about creative ways to address stress that was presenting in our staff that was impacting work. We had to think about creative ways to meet the needs of our clients who were relying on that in-home support to navigate during the postpartum period. And then also having to think about the mental health of our clients, similar to what's happening, I think, across this country, where mental health crises are surging, where domestic violence is surging. And so those are things that we had to think about more intently with our population, and then creative ways to continue to meet the needs in terms of our support services.
Okay, thank you, Asa. Very interesting points. Diana, why don't you tell us from how COVID affected your midwife practice?
Sure, we had a lot of workforce redesign issues specifically related to COVID. And when I think back upon them now, I really think of three bright spots that came from this. Not just locally, but nationally, we abruptly halted low value care. And it was shocking to me to think, wow, it was that easy. It just took COVID-19 to realize that the risk benefit ratio of overused antenatal testing or inappropriate elective induction of labor, those risks were too high for the population. So if we were capable of stopping it because of COVID, think of what we would do if we treated racism like COVID. And we created these workflow redesigns. So it's really, that intersection there has been important. The second workforce redesign, which has already been discussed, was of course our increase of utilization of telehealth. We already had an innovative telehealth program, but we were really able to take it to scale, including now using the third application. So we've learned 3 telehealth systems since COVID came out. So think about that. We already heard the workforce burnout that was happening because of the 52 different protocols coming out every different day. But to think of having to learn 3 different computer systems on top of the 2 electronic health records we're already using. We did enjoy the expansion of telehealth and firmly believe that it increases access. We're able to meet people in their own homes with their families. It's as close to a home visit as we could get for antenatal care. So that's been fun. It has protected our clients, and it has also protected our vulnerable providers. And the third type of workforce redesign that came was Zoom. I just think Zoom has really revolutionized our workspace, especially with regard to quality assurance and quality improvement. So I sit on the Arizona Maternal Mortality Review Committee, and we've had unprecedented participation since COVID from our outlying providers. Our tribal providers, our rural providers have been able to participate because everything transitioned to Zoom. Same thing happened with our rounds at the hospital, as well as our weekly midwifery clinical meetings. So high performance teamwork comes from processes like meetings. Meetings are time intensive, they're not compensated, and using Zoom really helped us take off, information share, and actively engage in quality improvement.
Great. Thank you, Diana. So I'd like to invite all 3 of you now to kind of turn towards lessons learned with 8 months of experience under your belt. What lessons can you share with everyone on the line that can inform maternal health policies and practices going forward? And as you answer this, please consider both the negative lessons, things that you might have done early on that were clearly mistakes in retrospect, and that were not great adapting strategies, as well as, of course, the positive ones that improve maternal health outcomes, perhaps, and decrease racial and ethnic inequities. You've already spoken about things like staff morale, which I think is a really critical thing to raise. You've all relied increasingly on telehealth, so I'd really love to hear your experiences about how well you're reaching your clients, or are you really encountering that digital divide and losing touch with folks? This low value care notion was a very interesting one, Diana. So yeah, if we could talk about lessons learned. Diana, you want to start us off with this one?
Sure. When I think about the lessons learned and some of the pitfalls, I really started to think about the human nature desire to have absolutes and the need to have one size fits all approaches. To be binary thinkers, it's this or that, and we can't tolerate the in between. And our inability to tolerate uncertainty is what carves away at our ability to provide person-centered care and authentic shared decision-making, because it's in the spaces of unknown where patient preferences should drive our outcomes and our processes the most. So I can think of two clinical scenarios that relate to this. One relating to trying to increase our birth center utilization, and the second relating to how we were managing our home visit program and the necessity in both of these cases to not be binary thinkers. So with regard to increasing birth center access, this started pre-COVID. As you hopefully are aware, the Urban Institute completed an analysis on the effectiveness of the birth center model of care, demonstrating that it is the appropriate level of care for the majority of Medicaid beneficiaries. So knowing that this is an evidence-based model that needs to go to spread and scale, we have been working in Southern Arizona to spread the model to our minority populations. Over a year ago, we realized that our birth center was being utilized more by our white, non-Hispanic, privately insured patients than our communities of color. And this bothered us. So we realized we had some structural racism that was occurring within our institution. So we embraced using quality improvement processes to break down these structural inequities and to listen to people. We used shared decision aids to be able to make sure that the community understood what their options were. And we listened to them and modified our practices to be able to provide preference sensitive care to acknowledge their preferences. This ultimately led us, and many other factors, to transitioning from our freestanding birth center to a Commission for Accreditation of Birth Centers accredited alongside midwifery unit. Because when we talk about cultural relevance, that's what we were hearing from our minority populations. It wasn't safer, they understood that, but that is where they wanted to go. And so we had to stay nimble and listen to the preferences of people, adhering to the model, using quality levers of accreditation to preserve the model, but to be able to really modify our plans to listen to people to expand access to this model of care. And I'll save my home visit story for later.
Okay, great. We'd love to hear it. Aza, how about you? What are some of the lessons you've learned over the past several months?
I think the biggest lesson learned is that our clients do not enjoy telehealth because they told us so. And even though they are, they're going with the flow of things, that is not the way that they enjoy receiving care. The other lesson that I think the other lesson learned is so for the past, since we've started our organization, so for the past 7 years, we've been conducting a workforce development program that trains perinatal health workers, utilizing a similar framework as community health, just more expansive and specific to perinatal health. And historically, that training has been all in person. And for this year, we had to completely transition that training online. That training, actually going through that experience, we were really hesitant. We were nervous about how the trainees were going to navigate some of the difficult topics that come up during the training. But what we realized was that it worked. So there are aspects that for in 2021 that we are carrying forward and thinking about how we restructure our training to be a more hybrid model where there's elements that are online and then elements that are actually in person. So it actually ended up solving a problem that we've been trying to fix for a little while. So I'm very thankful for that experience. And I think the last lesson, and this is a little bit outside of Mama Toto, but it actually is informing how we are thinking about our expansion into the clinical space in the very near future, in next year, 2021 and beyond. So one of the observations was as care transition, prenatal care and postpartum care transition to be primarily telehealth, that patients were actually inadequately prepared with the supplies that they were given to facilitate adequate prenatal care. In my own home birth practice, I also had to transition mainly to telehealth, even though I did still do a limited number of in-person visits. But I provided my clients with a prenatal kit inclusive of a Doppler and a blood pressure cuff and the things that they would need for me to feel comfortable having a prenatal visit. And so taking those lessons about how that actually work and comparing that to what I've seen with our clients at Mama Toto, who oftentimes some clients receive nothing, some clients only receive the blood pressure cuff, and really thinking about as we are existing, who knows for how long in this telehealth space, what is necessary so that our quality of care does not diminish, and that we are not sacrificing quality for, I don't want to say for the convenience, but in some way for the convenience of telehealth.
Very interesting. Okay, great. And Kim, how about yourself? How about at Healthcare Access Maryland? What are the lessons that have emerged for you?
Well, it was a lived experience. One thing that we pride ourselves at HCAM is that about 70% of our workforce are Baltimore City residents. When they are serving the members of the community, whether they're licensed professionals or paraprofessionals, they're Baltimore City residents. And so they are really truly working to improve the life course of their neighbors and of their friends and families. And so as we were really charged with making sure that we remained the safety net, the community safety net, keeping families and pregnant moms connected to resources and benefits, our team was really passionate about doing the research, finding out what's available, because not only was this valuable information for their clients, but it was also valuable information for their families, their neighbors, their church members. And so they were really connected to this experience as to what was available and how we could connect people through a system of referrals to make sure that not only are we viewed as a resource, but that we're connecting to those resources to say, my clients need you, and what can we do to have this collective relationship. And so we started there in being better advocates, not just talking about the experience of telehealth and how you can prepare for a telehealth visit with a provider, but then we started to help clients problem solve. If you feel that you need emergency room care, have you ever called that 24-hour nurse line that we are always telling you about connected to your managed care organization? Or as MCOs are, our partners at Maryland Medicaid are expanding their benefits and services in the light of COVID, have you given a call to those providers to say, I think it's time for me to learn about pharmacy delivery or transportation to my next lab appointment? Not just the healthcare provider touch, but those diagnostics that are so important and necessarily timely for us to provide good care to our clients. We had to start really giving the pep talk to say, no, you can't walk through the doors and do that walk-in appointment, but WIC is still taking new applications. Are you worried about eviction prevention or energy assistance or even water assistance? Really staying on our tiptoes about the timeliness of applications, the required documentation, what do you have at home, what could be electronically submitted on your behalf. We had to really start to take the time to take a deep breath and ask those important questions. Because just as we were surprised at COVID-19 and how it would change our practice, our clients were also not prepared to apply for benefits and services online. And so we wanted to really say, what do you have available? How can we meet in the middle? And also take the time to just ask them, how are they doing? You know, having that trauma-informed care approach about the stressors of how this is influencing a pregnancy. How is it affecting you as a parent? One thing that we also found, and Diana touched on it, and I so appreciated it when she said it, professionals we're moving targets, and we are sometimes so busy. Us being in our virtual offices allowed us to really schedule time to speak to each other, to be collaborative, because we cared about the clinical delivery services of our clients. So we really had that shared goal in mind. And so we had to really start to communicate with each other on a different level to say, how can I work with you? And what information can my admin team send to you and vice versa? How do we make sure that it is protected and that we can still get the job done, even though we've been set with these barriers, so that our clients feel confident that we stand behind our name. And one thing that was critically important, that was probably the mistake, and we had the chance to reverse it, was that we thought about our workforce. And we thought about that work-life balance. Some of our staff love to get to work because that gave them the opportunity to put on that advocate hat before coming home to be mom and dad. And when work and home is in the same place, how do they have the endurance to be fierce client advocates, as well as competent parents, spouses, and partners? And so we had to look at alternative work schedules. And what we found was that when we made that accommodation, not only was our workforce more successful, but they were grateful for this opportunity. They wanted to show that it worked, because when we look to re-engage and we're going back into the community, we want to take this lesson learned to say, we can do much more from 8 to 4:30. If we change that 8 to 4:30 to a different range of time, we can get so much more done. And not only that, our clients are more available. They are actually grateful for an alternative work time, because as I'm schooling my child virtually, so are they. And so they have great appreciation for the accommodation to different times. And we've seen a greater level of success as a result.
Okay, thank you, Kim. Really interesting set of lessons that really range from kind of global efforts to address structural racism in your midwifery practice, but then really nuts and bolts things about, you know, getting the right equipment into mom's hands so that they can do home monitoring. And so let's take on our last question then and shift gears and start to look forward. Okay, all of you have a long history of providing patient and family-centered care, and given that history, what are the various COVID-induced policy and practice changes that you've experienced? What should be kept as we move into the future? What should be changed as we move into the future, you know, keeping in mind maternal health inequities? And maybe as you consider those, even toss in any thoughts you might have on what's standing in the way of us being able to keep and promote those things. Also, why don't we have you go first this time?
So I think that one of the things, I don't know who mentioned it earlier, but one of the things that COVID has demonstrated is how our especially Medicaid, but how our insurers, our payers, can magically decide that all things are covered now, especially telehealth, when for so long, I know that people have attempted to get Medicaid to cover telehealth services, and it was almost as if we can't do it. But then COVID happened and everybody can do it now. So I do think that that is something that we should bring forward into the future, because I think that, again, especially thinking about rural communities where we are existing in a time of extreme maternity care deserts, extreme disparities in maternity care, that it does create the opportunity to bridge that divide. I also think COVID has been very gracious for midwives, midwives that are working in out-of-hospital birth settings, to not only make midwifery more accessible to people at this time. I have seen in the DC area, there's more coverage of midwives. So Medicaid, especially in Maryland, is now, people can, through exceptions and through a process, can have an out-of-hospital birth covered by a certified professional midwife. I believe that nurse midwives already had that option, both in Maryland and in the district. We were able to pass the Certified Professional Midwife Act in DC, but through the mayor's mandate, for providers that are licensed in other states can practice in the district. And again, throughout the country, throughout the US, we have heard story after story where midwives are showing up, right, for birth. Here in DC also, there has been, I think, more acceptance of home birth as a viable option and out of hospital birth as a viable option. And again, really starting to think about these collaborative care models that don't just keep birth in a hospital for low risk people who could effectively give birth outside of that setting. And those are the things that I would like to see carried forward into policy with all the pathways of midwifery that we have available, the 3 different pathways in the US, for all of them to be legal in all 50 states, and that coverage and accessibility of those services are not relegated to people who have economic means to access them. And that also we can see a growth in workforce for Black midwives, for Indigenous midwives, for other midwives of color, as midwives of color, specifically Black midwives, only make up 2% of all the midwives in the US. And so those are things that I think I believe that through policy and through this experience, hopefully we will see a shift occur as it pertains to birth and birth access.
Excellent, excellent. Thank you, Aza. Kim, how about you?
I definitely have a pet peeve with the term state of emergency coverage. When we look at, and telehealth is definitely one of those topics that we have to really recognize. The expansion of telehealth coverage during this state of emergency has really been a pathway for us to prove and show that this has to be a coverage that extends past this time of COVID, but is a different layer to providing access to care for those that have problems with transportation, those that have problems with childcare. We should never have to make the decision of how do I get to an appointment? Do I go to the appointment? How far can I walk? We want people to get access to care, and we want it to be covered, and we want people to feel confident that they can request this service without any hesitation. The other thing that I really want to talk about is doula services. In Maryland, we need doula services to be covered by Maryland Medicaid. We talk a lot about the benefits of our clients working with doulas and how they are truly a health professional for the eyes of our clients, and they are tremendous health advocates. And as we talk about inequities and our Black and brown moms being able to unmute themselves and talk about their experiences, and having advocates to really stand behind them in action as to how we can really talk about the implicit bias that we see in some of the work of some of our providers, as well as their frontline staff. We need people to stand by them and to be advocates for them. And so doula services in our area. We have a great network of doulas that many times provide their services at no cost or low cost, but we want to recognize them for the impact that they have to our client population, and they deserve that respect as professionals in this arena. One other thing that comes to mind quickly is just the increased funding for medical assistance transportation. No one should ever have to wonder how they can get to an appointment. It's insane to have a mom try to decide, can I take my child with me to an appointment? And, you know, do I fit the criteria for medical necessity if I'm going for routine care? The answer should always be yes. And as long as they are seeking care for themselves or for one of their family members, to not just provide direct medical care, but to address some of those other social determinants of health that influence her health in general, these should be covered services. Transportation should never be a question as our Medicaid population are utilizing services and benefits.
Okay, thank you, Kim. Diana, why don't you take us home on this one? Both Aza and Kimberly made some good comments to set you up, talking about both midwifery as well as doula services. I'd be curious as to your thoughts on that.
We didn't plan this, but our theme is quite going to close out here on some very common threads. When I think of important policy changes that need to persist, I'm going to start with our Medicaid policy statement, policy changes. And I want to take what Aza said and really hold Medicaid accountable. A fragmented system that is not standardized is a driver of systemic racism. Okay, so I'm currently analyzing with my researcher hat 95,000 claims. So I want to distinguish, we have been allowed to do telehealth. We are allowed to do birth center birth and bill Medicaid for facility fees. That does not translate to us being paid. The system needs to be transparent and we need to be paid for these services. So in 95,000 claims to Medicaid in 9 states for birth center services, the facility fee was reimbursed at a rate of 41%. Nurse midwifery services were reimbursed at 60% of billed charges. Physician reimbursement was reimbursed at 55% of billed charges. And non-nurse midwives received 31% of billed charges. That is not okay, and it's not sustainable. And as you look at the importance of increasing access, especially to culturally relevant Black, Brown, and Indigenous midwifery-led models of care in this country, they need to be paid. So we have to fix the broken Medicaid system if we're going to take these models to scale. So to further the points about the importance of providers functioning at their scope of practice, this was another miracle out of nowhere. Because of COVID, providers in states across the United States and in cities were all of a sudden allowed to provide at their nationally designated scope of practice, which was brilliant. It should have happened forever ago. It's shown us that we're capable of doing this. And so we need to maintain those policy changes. With regard to diversifying our workforce, we need reparation style funding of diverse Black, Brown, and Indigenous providers of all types: physicians, nurse midwives, doulas, community health workers, behavioral health workforce, everybody. But this needs full funding and serious consideration for bandwidth recovery so that people can focus on school and on service and healing. Those are, I think, very similar to what you just heard from Kimberly and Aza. I've, as a midwife on the ground, I've heard we're going to be paid by Medicaid for 20 years, and I have struggled with how I'm going to pay my staff.
Okay, very, very interesting and provocative. And I heard financing as one of the key things that folks are going to need to be paying attention to moving forward. But I also heard common threads about some silver linings, if you will, about how COVID has shown the crucial nature of all of the work that you guys do, and the opportunities to prove that to the world, which is just fantastic. I'm going to keep us on time. We are right at 4:30, so I want to thank you all very much. This was a terrific panel. And for the next part of our program, I'm going to hand back to Kima Joy, who will introduce our next guest, and will react to many of your comments with kind of a national perspective. So thank you, panel. We'll be back with you in a few moments.
Thank you so much. You guys were amazing. And as I said, like, those are the folks who are interrupting and enjoying it. And so it is with great pleasure that I introduce Dr. Oxiris Barbeau. She's a senior fellow for public health and social justice at JPB Foundation, but she was also former New York City health commissioner. And I always have to say this, although she hates it, she was also my first boss and really launched me on the path to pediatrics and advocacy within pediatrics. And so for that, I will always owe her. So Oxiris, you've heard a lot of the comments from the panelists, and you have a perspective, not just as former health commissioner, but having worked at Baltimore, having worked on the ground, having worked with the school system, and really being at the front line of thinking about and addressing inequities even before folks started to notice them, right? So what do you see, and how do you think government and policymakers should think about the balance between protecting patients and staff while also eliminating inequities and providing high quality outcomes? And what do you see are some of the barriers to achieving these goals?
Yeah, thank you, Kima, for that question. And I agree, it's a great pleasure and honor to be on the same panel with you. You know, as I am reflecting on what the previous panel covered, I want to just sort of step back a moment and set the stage that what I took away is a reflection of we are all living through a catastrophe. And the panel before us has really illustrated the fact that unlike any other disaster in our lifetime, this one in particular, we are both affected by it and adapting to it. And I think that they have really highlighted the ingenuity that has been born out of necessity, and the degree to which people in government, people in decision-making positions can take into account what we keep and what we lean more into from the perspective of what is it that we're trying to accomplish, right? If we are trying to accomplish better maternal health outcomes, but beyond that, eliminate the inequities that exist in this country, right? The fact that Black women are 3 times as likely, or excuse me, Black infants are 3 times as likely to die in their first year of life, that in New York City, Black women are probably 6 to 8 times more likely to die in childbirth. That's got to be where the conversation begins. And how do we then envision systems that will support those outcomes, and then figure out, you know, who do we pay what, and how is it that we support various models of care to get us to where we want to be.
Thank you. And I did want to, and I forgot to do this before, but we wanted to open the chat up, because I think while we're having these conversations, many of you are having reactions and can think of some of the ways that you adjusted during these times to really look at some of the inequities, and would love for you guys to be able to share those back and forth. So our Haley will open the chat and just give you guys that ability. And so, you know, we came upon many conversations around financing, and you even mentioned that once we understand where we're going and what our goals are, we can think about how we're going to pay for it. We all know, honestly, that is not policymakers' strong point. And I think that there is, you know, people are very fearful because there's going to be budget cuts because the expenditures we're making now, and for other political reasons. But with that reality and that framing, what are some of the things that you think are most needed in terms of policy or financing changes, like what should advocates and I use advocates not just as people who that's their formal job, but all of us who want to see a better world. What should we be asking folks to prioritize who are making those policy and budget decisions if we want to eliminate inequities?
Yeah, that's a great question, because I think it's multi-layered, right? We need to be able to ensure the capacity of the system to continue to provide services, which means that it doesn't just mean reimbursing physicians at an appropriate rate. It means reimbursing doulas and midwives at appropriate rates. But beyond that, I think we need to be realistic that there's going to be major budget cuts. And so there needs to be, I think it behooves all of us to have a strategy about what the end game is and how we present options. And I'll give you the example that for the last couple of years, we've been trying to promote in New York City, which is, we often talk about thinking outside of the box. I want us to forget about the box, right? Because the box by definition means constraints. And I think that as a group of advocates, we need to think about what are different models of care that don't provide care from the perspective of convenience to the provider and the healthcare delivery system, but that take into consideration the needs and desires of communities. And so one of my favorite models that we've been trying to push here in New York City, as well as New York State, is centering pregnancy. And the reason that I like centering pregnancy is because it has been demonstrated in states across the country to improve maternal health outcomes, specifically related to mental health, as well as infant birth outcomes. And the fact that we've done analyses to show that when you put the number needed to treat, which is a very sort of epidemiologically technical solution, but it's basically, a term that tells me how much do I need to spend in order to get return on my investment. So for example, if you treat 22 women through a centering for pregnancy model, you can avoid one preterm birth. And that's going to end up saving you anywhere, depending on where you are, $15,000 to $20,000. And so you multiply that by the number of women who can go through the model, and you quickly come to a perspective of this is not only a model that supports women's health, physical health, it's a model that can help save money, or not save money, because that shouldn't be necessarily the impetus. It helps direct money in the system to the right parts of the system in order to get better health outcomes, right? Putting 32 women through centering pregnancy can prevent one NICU admission. NICU admissions are incredibly expensive and avoidable. The last thing I'll say about centering pregnancy for right now is that the reason I like this model, especially during the time of COVID, is the degree to which people who go through the model report feeling a part of a community, and the mental health bonds that are built through this model that go beyond delivery. And I think especially in the time of COVID, when so many of us are separated physically, we need to create opportunities for us to come together emotionally and provide each other the support through these really hard times that we're all going through. So for me, it's a model that is cost effective, been proven to really improve outcomes that most affect Black, Brown, and Indigenous communities. And I think it's built for the COVID world.
Great, thank you. And I wanted to actually ask you a question from the audience because you have this broader perspective. And the question is, do you work with any populations who struggle with the ability to buy smartphones, tablets, internet subscriptions that allow telehealth to be successful? And if so, did you have strategies to mitigate this advantage? And I think some of our other folks will have ideas too, but just getting your broader perspective.
Yeah, you know, I've been thinking a lot about this, and it's never become so acute, right? The issue of access to technology. And what I've been thinking about is that we have to change the way that we think about technology, right? I need people to think about smartphones, routers, hotspots as equivalent to durable medical equipment, right? This is necessary technology in order to provide care. And we need to think about how it is that we finance it, right? So if a managed care organization can pay to send, you know, blood pressure monitoring equipment to somebody's house, pay to spend, you know, to send them weight checking equipment, then they should also be able to think about smartphones, routers, and hotspots as durable medical equipment and reimburse them that way.
Amen. Awesome. So I think we're at time. And you don't get to leave yet, though.
Wait, that went way too fast.
I know. But we wanted to leave. We only have 20 minutes.
Absolutely.
Time for Q&A, so you'll have more time to answer. And I wanted to invite all of the panelists back. Let's see, Diana, Aza, Kim. Wonderful. And I will note that Aza did say that she had to jump off early, so she may not be able to come back. Again, desperately want to thank you guys for being a part of our panel today, and wanted to go back to some of the questions that were brought up in the participants Q&A. And one I think is particularly interesting, related to kind of the work that you guys were talking about around racial equity. And it was saying, how are programs training on health equity with this, in many places, not everywhere, with orders that require us to stay in place and to work from home? How are you looking at racial equity, cultural competency training? Although I have issues with cultural competency, have to get it out. We will never be truly competent. Cities will have saw I was not competent and had to regroup, even though I was fluent in Spanish. And so I just want us to be humble about that. But how do we think about that kind of training while we have this order in place that requires us to stay at home? Who would like to answer?
Well, I can answer wearing the lens of being a nurse educator. So I work for the largest nurse midwifery university in the United States, Frontier Nursing University. We had distance learning before the internet. So if you can even think of that, we were engaging with populations of people who were wonderful nurses, had tons of potential to become providers, and but were living in rural Arizona and couldn't leave their families to go to a brick and mortar school in Albuquerque. And so, you know, bridging that, now, of course, we have the internet, but there are lots of ways to engage with communities using our virtual medium. I thought one of the comments that came up about telehealth that was really interesting, in our experience, while we did take telehealth to scale, 50% of our telehealth visits convert to audio only. And I think it's a sign that we've gotten too cute. So many of these apps are so hard to navigate, both from the provider side and the client side, that, you know, what happened to valuing the old-fashioned telephone conversation? I'm not saying it can replace face-to-face, but the same is true with a lot of our equity conversations and our ability to communicate across groups and to have meaningful engagement. I mean, we're really to the point where we have to move beyond these trainings and this knowledge level. You know, let's clear the knowledge deficit should be gone by now about racism. We need to move to the application level.
Awesome. Anyone else want to comment?
Thank you, Diana. I too share the passion to really uplift the conversation about an anti-racist equity approach to the delivery of healthcare services. And I work with Be More for Healthy Babies. We really speak a lot about how do we get what we see in the community and trends down to our providers that really are touching the lives of these clients to say, this is your product. when we say healthy parents are more likely to have healthy babies, well, when we see preterm births and low birth weights and increased infant mortality and fetal mortality, this is your report card. And we know that it is intertwined with that bias of how racism affects the delivery of healthcare. And we have to have those difficult conversations. Our country is in a very delicate place right now, where race relations and the discussions about diversity, equity, inclusion should be a point of discussion in every major organization, big or small. And so how do we first take that reflective moment to see how structural racism has affected who we are as professionals and as providers, and then do the work to address the elephant in the room and look at client outcomes to say, this is a result of racism. We did a bad job because of racism. And what do we need to do to hold our partners and colleagues accountable for a job poorly done?
Amen.
Kima, the only other thing that I'll add to what Deanna and Kimberly have said, which I agree with, is the fact that many institutions, and I would encourage more institutions to do so, build in how race affects the way in which a patient, quote unquote, shows up into their virtual simulations, so that they don't create educational activities around structural racism separate and apart from the everyday work of providing care, because I think that just builds or feeds into othering the work of working on structural racism. So to the degree that that's incorporated into simulations that, you know, OBGYN departments go through, any other departments go through, I think that that's a huge step forward.
Absolutely. And I think it's so amazing that all of you mentioned the need to really integrate it, but also the fact that we don't know how we're doing if we don't actually collect the data and see what the outcomes are. And I do have great fear that's something that maybe we're missing during COVID, that we're not doing that. So this particular question, it says to Diana, but I think everyone can answer it. And then there's a second part. Is what are the low value overuse antenatal procedures, and how do you balance that with concerns if these tests, et cetera, are not given? And it falls kind of into the next question. Are you concerned about birth or outcomes, maternal and newborn, with fewer in-person prenatal visits? Are there standard protocols among providers or in your communities? Is every provider deciding about who's high risk, who's low risk, and what tests are given?
So, you can go on to Choosing Wisely and see a whole list of low value perinatal care procedures. I think, our great failure across the nation has been our inability to implement evidence-based screening tools where you can assess risk. So it's not a mysterious process. We actually know how to do this. And if you start everyone at basic level 1 care, which will assume that all childbearing people have socio and behavioral risk factors as well as medical risk factors, and you figure out where they are, and then you get them to the appropriate level of care, which will involve a very different looking workforce. 80% of the population qualifies for what we call in this construct basic care. In fact, it's very enhanced care. But within that model, you don't need to be doing as many high cost ultrasounds as are being done, or twice weekly antenatal testing, or high cost genetic risk testing if the person's risk factors don't warrant that. All while you're losing the opportunity to implement evidence-based, culturally relevant care practices related to diet, nutrition, exercise, and stress reduction. So we've failed to incorporate the system to be risk-based. Do I worry about less prenatal visit? Now this will date me decades, Expecting Trouble by Dr. Thomas Strong, the perinatologist out of Phoenix. The myth of prenatal care, it's not about quantity of prenatal care, it's about quality of prenatal care. And how are we connecting with people, or how are we alienating people in the process? So, you know, we can do harm, and overuse is harmful. As a matter of fact, the medically low risk women are harmed more by overuse than women of medical risk. In our data of 144,000 perinatal episodes of care, we have demonstrated that elective hospitalization for childbirth, meaning going to the hospital when you don't have medical risk factors to necessitate hospitalization, is more harmful to childbirth outcomes than race and ethnicity. The worst driver in poor outcomes in our data is elective hospitalization, not race or ethnicity. So I just let that sit with you. Our systems are doing harm. So we need to really look at what's happening from those systems level.
Need to regroup. Others?
Okay.
Okay, Ian?
Well, yeah, I'll jump in just for a moment. Diana, you plugged the Strong Start evaluation, which we did at Urban, which found such positive impacts of the birth center model, the midwifery model. We also studied group prenatal care or centering pregnancy auxiliaries, and you're clearly a fan of that. So there were two questions from the audience. One saying, how has centering translated to a telehealth environment? What are your experiences there? And also a second question about someone acknowledging that centering pregnancy doesn't necessarily work so well for tribal communities because of the small numbers of pregnant women. And so maybe the first question to you about translating it to a telehealth virtual environment, auxiliaries, would be great. And then if anyone can comment on the experience of using group prenatal care with American Indian people.
Yeah, you know, one of the things that I'm as transitioning out of working for the health department, I haven't been able to really fully assess the degree to which we've been able as a city to support our providers and our participants in making that transition to using telehealth. What I will say though, which is I think an area that we haven't touched on probably as much as we should, especially in the COVID era, is that when we think about the communities that have been most affected by COVID, Black and Brown communities, we also need to think about the providers that provide care in those communities and the degree to which we support those systems. Because I think what's ended up happening is that hospitals, and I would say rightly so, have gotten the vast majority of the attention because of the degree to which so many people have required hospitalization for COVID and have ended up dying. But what we're finding is that there are a lot of people who aren't accessing care, and they can't access care because their providers haven't been able to get the resources that they've needed. And the concern is then what that then does to women who are seeking prenatal care and where they end up having to go. So when we talk about, you know, supporting models like centering pregnancy and supporting creating communities for patients, we also need to think about supporting the infrastructure that these practices need in order to fully leverage telehealth.
Diana.
I can additionally address, I can't believe I left this out of my Zoom story. One of the things that the Strong Start impact analysis showed with regard to centering were the logistical challenges. And we've experienced that personally. I've experienced it in 3 practices. I am very biased towards the model. It's where the magic happens. It's how we're getting high quality social determinant changes within our population. We have very good uptake in that within our Hispanic population here in Tucson. Zoom skyrocketed our participation. People were much more interested in coming within that environment. Something about having to come in person to a group. I don't know whether we're all traumatized from school, and there's just something about anything that sounds anything like school. I don't want anything to do with it, but there's something there. Zoom was a great innovation for us in this model.
Any comments on the American Indian population and how their equity is being affected by all of this.
Well, I have worked as a locum on the Navajo reservation in Tuba City, and I can say that they have suffered grave inequities as a result of COVID. I don't think that the nation is as aware that there is not running water in places. So when we're talking about wearing masks and using hand sanitizer, the basic thing before that was washing your hands. And when you don't have access to running water, it's really challenging. So there were major barriers. And again, our providers, our native providers did such incredible work to mitigate the risks and to really get out and do community participatory engagement around this. And they had good results with that. With regard to centering, I can't speak to that personally. I have heard that. But we do have within my system, we have collaborative relationships with group care that are very high functioning here in Tucson with the Pascua Yaqui tribe. So I'm not sure that there are absolutes in that regard.
I think one of the things that we need to think about is now that we are creating new communities virtually, what then that opens up for populations where there may be small numbers of people who are pregnant, and then connecting them to similar communities across state lines, right? I think that's one of the innovations that we need to think more about in terms of continuing to allow providers to practice across state lines for these very reasons.
Yeah, I completely agree. And I know it's time for us to wrap up, but I did want to stress the fact that there are going to be some things that are recommended that are not one size fits all and aren't going to be perfect for each community. And we have to admit and be comfortable with that. But I think the key is what that means is listening to the community to see what is going to be effective and what they are searching for in order to help solve the inequities, help engage, help build that community spirit. And so I want to make sure we don't give the impression that there's one size fits all. It's kind of like with my whole cultural competency issue. It's like we have to listen, be person-centered, work in partnership with community, and often community, especially in times of trouble, they're going to develop those solutions faster than policymakers, right? And we have to listen and be able to change policy to be responsive to those needs. But I know that we're almost at the hour, so I'm going to pass it over to Ian just to wrap it up.
Okay, great. Well, I'll just finish up with a bunch of thank yous, actually. Kima, at the outset, you said that we didn't come here to provide anyone with all the answers, but I think our four panelists have really taken us several steps in that right direction. And I really want to thank Kim Lyles, Azan Nadari, Diana Jollis, and Oksana Sparbo for their great input. I want to thank all of you out there in the audience. You had some terrific questions. We weren't able to get to all of them, but we will follow up with you and start fielding them out to our panelists so that you can get some answers. So thank you. I want to thank the team that worked on this over the last 8 months. You all know who you are: Kima, Sarah Benatar, Jenny Haley, Ava Allen, Sarah Kokiat, and Emmy Burrows. And finally, I really want to thank the Robert Wood Johnson Foundation and our project officer, Mona Shaw, for giving us the support and the guidance and the good counsel for doing our work. On the event page, you will have received links to 2 of the papers that we have developed. The one on the patient-provider experience and the one on telehealth. 2 more will be coming very shortly, one on financing challenges and one on data and accountability. And you should all keep your eyes out for a 5th and final paper in this first part of our series, which is going to kind of summarize and encapsulate all of the opportunities as well as barriers to addressing maternal health inequity during the time of COVID. And we're specifically going to design that paper to reflect the conversation that went on here today. So if any of you have any further follow-up and questions, please don't hesitate to reach out to us. We'd love to hear from you with your ideas and your feedback. And with that, I will say farewell. Thank you so much. This was really a terrific event. Bye-bye.
Thank you, everyone.
Thank you.
Thank you.